Hey everyone, today we're taking a close look at a bacterium that, for years, most of us in the lab probably dismissed as just a contaminant. But what if it's actually a whole lot more than that? We're diving deep into Corynebacterium pseudodiphtheriticum. Now, all the info in this explainer was put together using Gemini Deep Search, and if you want to check out the primary sources, you can find the complete list in the notebook document that goes along with this. All right, let's get into it. So, for decades, right, you see a diphtheroid like this pop up on a culture plate. And what's the first thought? Probably, it's just skin flora. Came along for the ride. But is that really the right call anymore? We're going to explore exactly why the answer to that is becoming a really firm no. So here's our game plan. First, we'll talk about its journey from a harmless bystander to a real pathogen. Then we'll jump into the nitty-gritty of lab identification and the kinds of diseases it can cause. After that, we're going to tackle the tricky business of treatment, and we'll wrap it all up with some essential infection control practices. Okay, so let's start with its kind of double life. Corynebacterium pseudodiphtheriticum isn't new, but the way we think about it is definitely changing. This is really the story of a pathobiont, an organism that's usually fine, but can flip a switch and become a problem, and how it's making a comeback as a big clinical concern. So what in the world is a pathogen? Well, think of it like this. It's an organism that's part of our normal, healthy microbial community, just living its life. But when the situation changes, say a person's immune system gets weaker or something else disrupts the local environment, it sees an opportunity, and it can become a real pathogen. So what was the big game changer? It was technology, specifically MALDI-TOF mass spectroscopy. Before MALDI-TOF, identifying these guys was slow, it was often ambiguous. Now we get a precise species ID in minutes. This incredible leap in our diagnostic power is the main reason we're finally seeing Corynebacterium pseudodiphtheriticum for what it is, a genuine, recurring cause of infection. All right, let's head over to the lab bench. For all you microbiologists watching, this next part is for you. We're going to break down the key characteristics you need to spot this organism and, just as importantly, tell it apart from its relatives. Okay, so under the microscope, there are some classic clues. You're looking at a gram-positive bacillus, but it's pleomorphic, meaning the cells are all different shapes and sizes. You'll see those irregular, club-shaped coroniform rods. And because of the way it divides, this cool snapping motion, you'll see those classic arrangements. V-forms, neat parallel rows called palisades, and those angular clusters we all know as Chinese letters. And on the culture plate, it's not too picky. It grows just fine on standard sheep blood agar. You're looking for small, whitish, kind of dry-looking colonies after about 24 to 48 hours. A really key feature here is that it's non-hemolytic. It's gamma-hemolytic. And, of course, being a gram-positive, you won't see any growth on your McConkey plate. So, how do we nail down the ID biochemically? This table makes it super clear. The two huge standouts for Corynebacterium pseudodiphtheriticum are its rapid positive urease test and the fact that it does not ferment glucose. Honestly, those two tests alone are often enough to separate it from the big players like Corynebacterium diphtheria and Corynebacterium striatum, which are both glucose fermenters. This really shows just how far our tools have come. We started with biochemicals. They worked, but they were slow. Then came 16S RNA sequencing, which was a nice step up, but sometimes struggled to tell very similar species apart. The RPOB gene gave us much better resolution. But today, there's no question. MALDI-TOF MS is the standard of care. It's fast, it's accurate, and it's what we need in a modern clinical lab. Okay, so we know how to find it. Now, what does it actually do? Let's take a look at the clinical side of things and the different diseases this opportunist can cause. The switch from being a harmless commensal to a pathogen is really all about opportunity. The people who are most at risk are those who already have some vulnerability. We're talking about patients with chronic lung issues like COPD, people who are immunocompromised, patients with things like catheters or prosthetic heart valves, and the elderly. Since its natural home is the upper respiratory tract, it's really no surprise that this is where it causes the most trouble. It can be responsible for anything from making chronic bronchitis worse, all the way to causing a really severe pneumonia, both in the community and in the hospital. And this is probably its most dangerous trick. It can actually cause a pharyngitis with a pseudomembrane that looks exactly like classical diphtheria. This is a huge problem for clinicians. The treatment for real toxigenic diphtheria is giving antitoxin immediately, which is totally wrong for Corynebacterium pseudodiphtheriticum. This is where a fast, accurate ID from the lab becomes absolutely critical to prevent a serious mix-up. Which brings us right to the next big challenge. Once we know what it is, how do we treat it effectively? Let's get into the complexities of antimicrobial therapy. So, the surveillance data paints a really clear picture. It's almost always susceptible to beta-lactams like penicillin and ceftriaxone, and drugs like vancomycin and linezolid? Rock solid, with basically 100% activity. But then you look at the other side of the coin, and you see widespread resistance to macrolides like erythromycin and to clindamycin. We're talking susceptibility rates that are often below 25%. It's a huge difference. This chart just makes that point so visually obvious. I mean, look at that. You have these super reliable drugs like vancomycin and penicillin way up here, and then this massive cliff dive down to something like erythromycin. This stark contrast is exactly why you have to run susceptibility testing on every single clinically significant isolate. You just can't guess. And now we've arrived at the single biggest headache for labs, especially those that follow European guidelines. As of 2025, EUCAST, the European Committee on Antimicrobial Susceptibility Testing, has not set specific clinical breakpoints for this organism. This is a massive gap. It means we can get an MIC value from our instruments, but we can't officially call it susceptible, intermediate, or resistant. Right now, the recommendation is to just report the number and tell the clinicians to consult with an infectious disease expert. So without those official breakpoints, we have to fall back on principles from published studies. For a really sick patient, starting with vancomycin is the safest way to go. Then, once you get your susceptibility results back, you can hopefully de-escalate to something like penicillin if it's susceptible. For kids, it's pretty much the same idea, just with careful dosing by weight and, of course, avoiding certain antibiotics. But the absolute golden rule, no matter what, is that the final therapy has to be guided by those AST results. And finally, let's talk about how we stop this thing from spreading around in a hospital. This is yet another place where knowing it's not its more infamous cousin is completely essential. The infection control playbook for these two organisms could not be more different. For Corynebacterium Pseudodiphtheriticum, you start with standard precautions. Maybe you add droplet or contact precautions if the patient has a bad cough or something. But for toxigenic Corynebacterium diphtheria, the response is massive. Mandatory droplet precautions, calling public health immediately, and doing extensive contact tracing. Getting the ID wrong can lead to a huge, unnecessary public health response. And that really brings us to the final thought. With it being recognized more often, the lack of official breakpoints, and that potential for clinical confusion, this organism is a real challenge. So the question I want to leave you with is this. What is your lab doing to actively help clinicians make the right call, both for diagnosis and for treatment, when they run into Corynebacterium Pseudodiphtheriticum? So how does your lab handle this bug, especially with that breakpoint issue? I'd love to hear your approach and what you've seen, so please share your experiences down in the comments. And if you found this deep dive helpful, please subscribe for more explainers on key topics in clinical micro. Thanks so much for watching.